And thank you for joining us today. I know it's been a long day of lectures, and thank you for joining us today. We're going to be talking to you today about biologics in the use of chronic sinusitis with nasal polyps, putting a paradigm shift into the practice. And I think that makes a lot of sense because with the introduction of biologics, which is a new class of drugs that we can use for nasal polyp, it really has shifted the way we treat our patients with nasal polyp. And so my name is Joseph Hahn, and I'm here with Seth Isaacs, and we'd like to thank Peer Review for providing the support for the sessions, and we'd like to thank Regeneron and Sanofi for supporting the event. And I think you already answered the pre-event survey. And so here, if you haven't done it, here's the QR code so that you can load it to your device. So we do have some audience response questions that we do want to ask you during the presentation. So if you can click on that, you could be able to answer some of those questions. And so, and you can also visit peerreview.com 2024 CRS with nasal polyps to get some practice aids and download some of the things after this event. And so the goal of today is to talk about chronic sinusitis with nasal polyp. You know, what does it mean when we say type 2 inflammation, and what does it mean when we're saying nasal polyp is a type 2 disease? How do we decide which of these patients are candidates for nasal polyps? How do we create a multidisciplinary approach to treat our patients, and why is it important to have that? And at the end, you know, if we do put a patient on a biologic, you know, how do we assess them and continue treatment for these patients and while they're on biologics? And so, as I said earlier, my name is Joseph Hahn. I'm currently a professor at Eastern Virginia Medical School, and you know, I know biologics has been around for about 5 years now, but for me, this is something that's been in the works for me for 20 years. And so when I initially started teaching at University of Virginia and started getting NIH grants looking at what is causing nasal polyps, for me, biologic made a lot of sense. And so, and I've been working with a lot of the companies to try to get the biologics approved for nasal polyp. And if you look at a lot of the papers that talk about biologics for nasal polyp, you'll see my name across that. And so, you know, let's talk about chronic sinusitis. And so, you know, what exactly is it? Well, I think we're starting to realize that it is no longer an infectious disease process. When we usually talked about chronic sinusitis in the beginning, we thought it was an infectious bacterial-based disease. But now we're really starting to realize it really is an inflammatory disease. And some of it can be inflammation caused by infection, or sometimes it could be inflammation by overdrive of some of the inflammatory pathways. And when we talk about chronic sinusitis, it really is a chronic disease. Most of these patients have symptoms for at least 12 weeks or longer. So like for acute sinusitis, it lasts about 4 weeks. For chronic, it's 12 weeks or more. But I would actually even say that there are some chronic sinusitis that are a little bit shorter, like odontogenic sinusitis. That is a chronic sinusitis, but once you get rid of the infection and control the infection, it's gone. But for something like aspirin triad or ARD, once you have that diagnosis, you have that diagnosis for life. So there are different levels of duration of the disease. And if you look at the most common prevalent symptoms associated with chronic sinusitis, is drainage, congestion, facial pressure, and lots of smell. And in fact, the symptoms kind of vary based on what type of sinusitis you have. So if you have a chronic sinusitis without nasal polyp, you're more likely to get the facial pressure and nasal congestion, while if you have nasal polyp, you're more likely to get lots of smell. And then, you know, because some of the symptoms do overlap with other diseases, you do want to have some objective way to measure that. So a nasal endoscopy is the easy one to do. And I would say, you know, for research purposes or for other studies, you know, a CT scan seems to be the gold standard in documenting the evidence of sinusitis. And as I mentioned before, these are some of the common symptoms that we see, and including cough. And so there's a disease called upper airway cough in patients with ectopic-driven disease process where the sinusitis is causing the cough. The sinusitis can also extend to the eustachian tube and cause ear problems. And we know a lot of patients with chronic sinusitis tend to be associated with anxiety and depression. And the other thing is if you can't breathe, the fifth most common symptom in chronic sinusitis is poor sleep. So if you're not getting good sleep, you can't function well. Now, when we look at patients with chronic sinusitis, I think a CT scan is a good way to kind of differentiate looking at patients with nasal polyps. So if you have someone like a CT scan like that was one of my patients who already had sinus surgery, and the patient had pansinusitis. And so when the sinuses are completely blocked like that, these are patients that are very suspicious for having nasal polyps. The picture in the middle, the endoscopic picture, that is a picture of nasal polyp and fungal mucin, eosinophilic fungal mucin. And so that is also an example. And then you see the picture on the way on the right side, that is nasal polyp with pus. And that's actually kind of interesting because, usually when you have someone with sinusitis, it's usually just polyps or usually pus. Sometimes you'll get a little bit of the two, and there are certain diseases where you get both infection and nasal polyp, but most of the time it's usually nasal polyp or just pus in general. So when we talk about chronic sinusitis in the US, we break it up based on the presence or the phenotype of nasal polyps. And so we have chronic sinusitis with polyps and chronic sinusitis without polyps. And I would say roughly about 0.25% of the people with chronic sinusitis have nasal polyps, and about 3/4 of those patients don't have nasal polyp. Now, there were some recent papers that were looking at chronic sinusitis patients, looking at the patient's endotype, looking at their inflammatory cytokines, and they were saying it's about 50-50. I don't think that's necessarily true. In my practice at a tertiary rhinology center, academic center, I would say it's half and half. But in general, it's usually about 1/4 to 3/4. And that tends to be a very common ratio that seems to play out throughout the years. And then, certainly if patients have a history, if you challenge them with an NSAID and they have symptoms within 3 hours, and it tends to peak in 90 minutes, if they have a problem with any kind of NSAIDs, you certainly have to think about aspirin triad or ARD. And if they have 2 history of NSAID exacerbation, that by definition is aspirin triad or ARD. Now, when we look at the different types of chronic sinusitis or nasal polyp, we see that there are other type 2 diseases. And so, so chronic sinusitis with nasal polyp, if you look at the endotype, it is clearly a type 2 based disease. And there are other comorbid diseases that are type 2 as well, allergic rhinitis being the most common one, but asthma is probably the most relevant one. And so if someone has, so when I talk to pulmonologists and they have asthma, and I'll ask them, are you asking if they have nasal congestion or if they have loss of smell? And I say, if they have any kind of nasal symptoms, you gotta assume that they have sinusitis. If they start losing their sense of smell, you gotta assume that they have nasal polyps. And so just as much as we underdiagnose patients with asthma, I think a lot of the pulmonologists underdiagnose people with chronic sinusitis and chronic sinusitis and nasal polyp. And they really do go hand in hand. And we know that if you have asthma, it tends to be what we call a high type 2 disease, meaning it's higher levels of those type 2 inflammatory cytokines. And then of the patients with nasal polyp, we know about 20 to 25% of these patients usually will have aspirin intolerance or NSAID intolerance. And I'll talk a little bit about who they are in the future, so in the next couple of slides. So now let's kind of shift gear a little bit and let's talk about, how do we how do we identify these patients, and who are these patients that would benefit from biologics, and what are some of the efficacy results of biologics in treating our patients with nasal polyps? So I know maybe many of you guys don't like the immunology, but you do have to understand it because just like asthma is now an epithelial, a lot of people are thinking it's more of an epithelial type disease. Same thing with chronic sinusitis with nasal polyp. I think we're starting to realize that a lot of the problem tends to be starting from the epithelium. And so, in the past, we used to say, Th2 inflammation, and now we've switched it over to type 2, and I'll tell you why that is. And so if we talk about Th2, we talk about the allergies going through the epithelium, then having the T helper cells secrete the IL-4, IL-5, IL-13. But what we're starting to realize, it isn't just the allergens that's causing that. Viruses can do that. And that's why anytime you get a viral infection, your asthma can get worse and your sinusitis can get worse, right? And then you could also have pollutants that can also irritate the epithelium. And so when the epithelium gets injured, it'll secrete three types of alarmins: IL-25, 33, and TSLP. For chronic sinusitis with nasal polyp, the most significant alarmin probably is going to be the TSLP. And so, and then those alarmins then activate the innate lymphoid cell 2, ILC2 cells, which then make the IL-4. IL-4 then converts the Th0 into Th2. The Th2 or the ILC2 can make IL-4 and then make the plasma cells turn into B cells, and the B cells then can make immunoglobulins, even IgE, and the IgE binds to the mast cells and causes that whole inflammatory cascade. I know that was a lot of immunology, but it's important to remember, because by knowing that, now you understand why these biologics work. And so, starting at the top, we know that patients with nasal polyp, corticosteroid is pleiotropic. It covers everything, right? So regardless of what the inflammation is, corticosteroids can stop it. But it's too broad. And we know that steroids can cause problems. So we want to try to be more specific. And so that's why we have biologics or monoclonal antibodies that target IL-5. And there are three biologics that target IL-5 is mepolizumab, resilizumab, and benralizumab. But the only one that's actually approved for nasal polyp is mepolizumab, and benralizumab is different than resilizumab, mepolizumab, because benralizumab binds to the IL-5 receptor, which is different than mepolizumab and resilizumab. And then we have dupilumab blocking IL-4 and IL-13, and that's dupilumab. And the way it blocks IL-4 and IL-13 is it binds to the IL-4 receptor alpha. And that is really important. So let me kind of, why is it so important? So, there are clinical studies that looked at targeting asthma by just using IL-4. It didn't work. And when they did a clinical study targeting just IL-13 for asthma, it didn't work. But when you're targeting IL-4 and IL-13 together for asthma, all of a sudden it will work really well, not only for asthma, but for a lot of other disease. So it's really important to target that dupilumab to target both IL-4 and IL-13, and that is a very important mix. And then we talked about the plasma turning to B cells, making immunoglobulin IgE, and so omalizumab blocks IgE, and so and that's how that works. So understanding that whole immunology or that immunologic pathway for causing nasal polyps is really important and to understand why these biologics works for our patients with nasal polyp. Now, traditionally, when we think about how do we treat our patients with nasal polyp, and this is pretty much from the ICAR, the International Consensus of Allergy and Rhinosinusitis, the way we typically treat patients, and this is pre-biologic era, is we do nasal saline irrigation, topical nasal steroids, and different ways of using topical steroids. Antibiotic doesn't work very well in patients with nasal polyp, but it is there. Leukotriene modifier definitely seems to work very well in patients with aspirin triad, but the efficacy seems to be variable, and the literature isn't very good because no one's actually did a really good job looking at leukotriene modifiers for the nasal polyp. And certainly systemic steroids seems to be probably the most effective treatment that we have. But the problem with steroids is that it causes a lot of side effects. So how much is too much steroids in our patients with nasal polyp? So most experts would say it's 2 doses of steroids in 1 ear is too much. And in fact, if you look at the asthma data, it's very similar data. If it's more than 500 milligrams or 400 milligrams a year, that's too much steroids. And the problem with steroids is the cumulative dose of a steroid is what causes the problem. And so it's about 1 gram of systemic steroids is what it takes to start having these side effects go up, and it's 1 gram. So that's 4 doses of systemic steroids for our patients with nasal polyp starts increasing these risks that we see here. And so that's why if they fail medical treatment, we consider doing sinus surgery. And when we do sinus surgery, these are some of the goals that we're trying to treat. We're trying to tailor the treatment. So just like we change the medical treatment based on the type of nasal polyp. Same thing with surgery. We do the surgery differently. So if they have big polyps, we make big openings. And we get rid of all the polyps and we decrease the inflammatory load in the patient. So we're getting rid of the eosinophils, the mast cells, all the inflammatory cytokines like IL-5, and then we want to make the openings really big because we know that surgery will not cure them of their nasal polyp. A lot of patients come in thinking that if you have surgery and you get rid of their nasal polyp is gone for good. But that's not true. We know that nasal polyp, even if you do surgery, will still stick around. So that's why we want to make big openings so we can get the topical steroids in there. And that's usually our main workhorse in our patients with nasal polyp is to do surgery and do medical treatment afterwards. And so we're going to ask a polling question to the audience, and I think all right, so the question is, rethink your choice, sinus surgery and chronic sinusitis with nasal polyp. And what's the right answer is 1, typically provides a definitive cure. Number 2, has been validated to be most successful in combination with biologic treatment. 3, improves the delivery of topical medication. 4, is intended to replace topical or systemic corticosteroid use. Or 5, I'm not sure. And so go ahead and answer that question, and I'll show you the results. Okay, so it sees that, yeah, so the majority of you guys are right. And so people pick that it improves the delivery of topical medication. And so the first answer provides the definitive care. We said it's not there. Has it been validated that surgery and biologic seems to be very helpful? I think the answer probably is yes, but it's not been studied yet. People are doing that study, so it hasn't been validated. We know that we do surgery and we make big openings that does allow better delivery of topical steroids. It's not intended to replace topical systemic steroids. And so you guys did great. All right. And as we mentioned before, this is a paper from Adam DeCon from UC San Diego. And what he did was he got 8 different tertiary rhinology centers, and they had patients with nasal polyp, did appropriate sinus surgery, and gave them medical treatment afterwards. And you can see that was published in 2017. So this is before the era of biologic. And so with surgery and medical treatment afterwards, people still had a hard time controlling the nasal polyp. And that's why the introduction of biologic is so helpful. So now, I bet you, with the introduction of nasal polyp, if we look at the recurrence rate, I bet it'll probably be lower. But you can see that the recurrence rate, even with good sinus surgery and good medical treatment afterwards, still didn't cure these patients. And so what are the biologics that are approved in the US? The first one that was approved was dupilumab. It was summer of 2019. And like I said, it blocks IL-4 and IL-13 by binding to the IL-4 receptor. And one of the things that in trying to decide what biologic do I use on our patients with nasal polyp, the first thing I look for is their comorbidity. What comorbid disease do they have? So if a patient has atopic dermatitis and nasal polyp, you know what I'm going to use? Dupilumab, because you can see that with those two comorbidity, it seems to be a good one. Dupilumab is also approved for EoE, so if someone has EoE and nasal polyp, that would be the one that I use. The next one that got approved is omalizumab, and that was approved the following year, a little bit after Thanksgiving. And that's approved for food allergy, recently for food allergy. I don't know if you saw that from the Quad AI. And so it's also approved for urticaria. So if someone has CSU and has nasal polyp, the one that I would be using is omalizumab. And then we have mepolizumab that got approved the following year. And if someone has EGPA and has nasal polyp, the biologic I would be used is mepolizumab. Now, so let's go through the data really quickly. And so you probably have seen this data around already. So this is from the Sinus 52. And so these are patients who were given dupilumab, and they were given dupilumab every 2 weeks. And then for Sinus 52, they had two treatment groups. One got dupilumab for 2 weeks, the other one got it for 4 weeks. And if you look at this bottom half, you can see that even if you got Q2 weeks and Q4 week, there really wasn't a big difference. And so that makes a lot of people speculate a lot of different questions. But and it seems like the longer you give the dupilumab, the patient continues to improve with the nasal polyp and their symptom score. Now, the other phase 3 study was Sinus 24, and that was where I was the lead investigator for that. And what we did was we gave patients dupilumab for 6 months. We stopped it to see what happens afterwards. And what we saw was that dupilumab had about a 2-month to 3-month durability, meaning that after 2 or 3 months, they had a little bit of a sustained effect. And so even if you stopped it, for 2 or 3 months, these patients continue to do well, even though they stopped dupilumab. And that's important, and I'm going to talk a little bit about that a bit later. Now, for me as a clinician scientist, I'm always talk about, SNOT 22, VAS, nasal polyp scores, but that's not what patients are interested in, right? What patients want to know is, do I have to keep doing sinus surgery? Do I have to keep taking systemic steroids? And so here, it shows that with dupilumab, you're able to decrease the use of sinus surgery or steroids by 3 to 1. So if you got dupilumab, you were 3 times less likely to have surgery or systemic steroids. And I think this graph showed that well. And it also shows that if you have comorbid asthma with a nasal polyp, you also had significant improvement in their asthma function as well. So this is omalizumab, and omalizumab did a little bit differently. They had the placebo group and the treatment group. They measured it for 6 months, and then they had an open label extension. So that meant that everybody could be on the omalizumab. And so what you see here in the placebo group here, look at this placebo group on the top. What you see here is that when these placebo group got omalizumab during the open label study, boom, it dropped. And so that tells you that omalizumab works. And then if you look at what happens after they stop the omalizumab, look at their sustained effect. It's only 2 to 4 weeks. So it wasn't as long as dupilumab, which was 2 to 3 months. Omalizumab, pretty quick reverse. And so that's actually pretty interesting. And then this is mepolizumab, so the Synapse paper. And so, and you can see that the patients had improvement in the nasal polyp score as well as their nasal obstruction. But and so this is the one that I kind of want to show you. So what happens is that if you look at the change in the nasal polyp score for omalizumab and mepolizumab, the nasal polyp score was about a 1-point change. But dupilumab was the only one that was a 2-point change. But the thing that's kind of interesting for me is what happens after you stop the mepolizumab. So when they stopped the mepolizumab, it seemed to show that the mepolizumab had a little bit longer durability or a little bit longer sustained effect. And in fact, based on this paper with Martin Durossier, it looks like they had about a 6-month durability or a sustained effect, which is interesting. Now, these were, now to be fair, there is no, you can't say one is better than the other. There are some indirect treatment papers that have come out. But the problem with the indirect treatment comparison is that not everything is equal. And so you can only infer things from there. And that's probably as good as it gets unless somebody does a head-to-head study. But there are 2 papers that did a systematic literature review. And the problem with these systematic literature review is they're incorporating all the different studies. So like whether it be phase 2 or phase 3. And there are different criteria, different study population, but the bottom line is all the 3 biologics that got approved by FDA seem to work in patients with nasal polyp. But the one thing that I think was really interesting was the sense of smell. And so if you look at the 3 biologic, the one that seems to have the biggest impact on sense of smell is dupilumab. And these were patients who were getting their sense of smell pretty quickly. And so we were in the study, and these patients who were getting dupilumab, well, we didn't know if they were getting dupilumab or placebo, but the patients were convinced they were getting dupilumab because they said they got their sense of smell as early within the first week. And the other ones do have improvement in smell, but it takes a little bit longer. And one of the reasons why maybe is that there may be an IL-4 receptor in olfactory tract based on an animal model. We'll see if that's also true in a human model as well. And that may be why dupilumab is able to improve their sense of smell more quickly. Now, remember I said there was no head-to-head study? That's not true. Now, there is a clinical study called Everest. They just had the last patient enrollment about 2 weeks ago. And so this is the Everest study. And so what they're doing is they're comparing dupilumab to omalizumab. And so we'll see what that study shows. And so they have enough people recruited for the study, and we'll see what that shows. And so now we can actually say, is dupilumab better than omalizumab, or is omalizumab better than dupilumab? We'll see what the study shows. And we'll have that data in about a year. And so now there are other studies that are phase 3 studies looking at chronic sinusitis with nasal polyp. And so we have benralizumab. And actually, their first phase 3 study was Oxalis. And their second one, which was based more in Asia, was Orchid. And so they finished their last recruitment for that last fall. Depemokimab is similar to mepolizumab. And because it's similar to mepolizumab, remember I was saying that the mepolizumab had a sustained effect for maybe about 6 months? Well, depemokimab is given every 6 months. So all the other biologics are usually 2 weeks, 4 weeks, at the most 2 months, but depemokimab is given every 6 months. And so that had the last patient in last fall as well, and we'll see what that shows. And then the waypoint, which is the tezepelumab, that one targets the TSLP. So remember we talked about the immunologic pathway, and we talked about the 3 different alarmins. And the 3 alarmins was IL-25, IL-33, and TSLP. And the one that I think seems to be the most significant one for patients with nasal polyp is TSLP. Well, tezepelumab blocks TSLP. And the reason why that's important is because if they're saying if you block TSLP up that high, can you then block all the other ones like IL-4, IL-5, and IgE at the same time? We don't know. So that is that study called Waypoint, and we have that going on. And then And before I finish there, and then there are other studies that are doing phase 2 studies as well. And actually, if you look at all these biologics for nasal polyp, they all end in MAB, right? Monoclonal antibody. If you look at the new biologics that target CRSRP, there's a one for phase 2. It's called Vericatug, TUG. If you look at the suffix, it's different because they're starting to run out of the suffix for MAV. And so now they're using TUG, ARC, MIG, and so there's a lot more coming down the road. And so with that, I'll end, and I'll turn it over to Seth Isaacs.
Great. All right, I'm going to wait here a second while my slides load up here. So I had to travel pretty far, about 15 minutes up the road, since I practice here in Cincinnati, and the majority of my practice is tertiary rhinology, so a lot of revision, sinus surgery, and refractory chronic sinus disease. There we go. So I actually think Dr. Hahn drew the short straw because he had to talk about all the immunology. I think I got the easier lot of getting to talk a little bit about, how we select patients, more of the clinical things. And I guess with a show of hands, how many people prescribe biologics right now or in practice is that do? Okay. And like we had talked about, or Dr. Hahn talked about, is the paradigm is shifting. For a while there we got comfortable with, what we call maximal medical therapy, failure of that leading to surgery, repeated surgeries, relying on long-term topical therapies with steroids, antibiotics, antifungals, and then biologics came along and have kind of flipped that whole paradigm on itself and continues to evolve. And so, the first thought is, how do we identify those patients that may benefit the most from a biologic? And so a lot of the papers, like the Euphoria, which is a group of physicians, nurses, people from pharma, even patients from, out of Europe, kind of looked at these criteria. And even though this was published in 2023, a lot of the meetings were done prior to any of these biologics being approved for CRS with polyps. And so first they wanted to look at who may be good candidates for a biologic. And so again, we want to look for those that may be predisposed to type 2 inflammation. And so, looking at this, these are all patients with severe CRS with polyps, severe meaning high polyp burden, and have multiple symptoms, including anosmia, and have required multiple treatments in addition to topical corticosteroids. And so they looked at these patients with severe CRS with polyps, and then you have to have at least 3 of these criteria. So evidence of type 2 inflammation. So, this could include, doing blood work and finding out that they have elevated blood eosinophil levels. If they've had prior surgery, on the pathology specimens from that surgery, were they able to measure the number of eosinophils per high power field? I don't know about Dr. Hahn, but it's very variable in our institutions, variable between hospitals and surgery centers, and even variable between pathologists. You can look at total IgE levels. And then more of the clinical data, how many rounds of systemic steroids have these patients been on? Again, have they been on more than 2 per year, which we know, is not sustainable with long-term side effects of corticosteroids? Or have we put them on even low doses of steroids? And has that been going on for over 3 months? And then also looking at symptoms. They've looked at using the SNOT-22, whether that was a score greater than 40, which we've seen in prior studies really has a significant impact on quality of life. Do they have a loss of smell? And, like Dr. Hahn had said, and you all see in your practices, loss of smell is probably the single most impactful symptom that these patients have. And then, do they have other comorbid diseases such as asthma, atopic dermatitis, allergic rhinitis? So our first polling question for my section. Rethink your choice. Which of the following statements about eligibility for biologic treatment for CRS with nasal polyps is true? 1, eligibility is based on a combination of objective and subjective assessments. Patients must have experienced polyp recurrence after greater than or equal to 2 prior sinus surgeries. Biologic use is reserved for patients with greater than or equal to 2 comorbid type 2 conditions. Or number 4, I'm not sure. Too bad they don't have the Jeopardy music. So I think that most of you were correct. I mean, it's based both on objective and subjective assessments. So, symptom scores, the types of symptoms and the severity of the symptoms that the patient perceives, as well as, nasal polyp scores, things that are more objective based on nasal endoscopy or even imaging. So again, determining when to initiate treatment with a biologic. So again, this is looking at patients who have severe CRS with polyps. So, usually a nasal polyp score of 4 to 8. Those with persistent symptoms, including anosmia. And then it's also in people who are uncontrolled. So meaning they have even failed treatments beyond topical nasal steroids. So corticosteroids have failed surgery. They are people who have other comorbidities such as asthma, NSAID, exacerbated respiratory disease. Those that we've done blood work and have seen high blood eosinophils or eosinophils within the pathologic tissue itself. And then, which I'll talk about in I think the next slide is, and then kind of discussing this with the patient, which is key, because just as the paradigm has flipped on us, or has evolved for us, the practitioners, it's also evolving for the patients. And so, including the patient in on the decision process, letting them know all their options and the risks of each of those options is key. And then, as is stated in the green box, and I'll talk about in further slides, is collaboration with other subspecialists, such as allergists, pulmonologists, the primary care themselves. And so again, the key in these patients is to engage them and to include them in the decision-making process, which is what we do with any other disease process, frankly. I think that, it's important as we see these patients, especially ones that maybe have presented with, newly diagnosed CRS with polyps, and are coming to you all from their primary cares, is that this is a chronic disease. People often still come to my practice and they want the quick fix. They still think one and done surgery is the key. And it's funny because they seem to understand the chronicity of their disease with asthma, but they don't equate it and transpose it over to their sinus disease. And so, that's always my first discussion with the patients, is that this is a chronic disease. You will not be cured of this. Even when I'm discussing surgery with them, I always make a reference to, gallbladder disease. If you have stones in your gallbladder, you take out your gallbladder and you can't have gallbladder disease because you don't have a gallbladder. But we are not ever removing the sinuses. Again, the surgery is set up to help drain the sinuses and then help to open things up so we can apply topical medications. And so, that is the first discussion, is that you have a disease and it requires both surgical treatment at times and medical treatment. And now with biologics, that discussion about medical treatment is pushed a little more in that direction. And so, with a lot of patients who come in and have failed prior surgeries, then the discussion is going towards biologics because, frankly, they're tired of having surgery. And so, again, it's important to discuss the risks and the benefits of both the surgical interventions as well as the biologics, and really have them be as informed as they can be. And then moving on, how do we, once we've chosen those patients, how do we monitor symptom resolution or improvement? And so, what I do in my practice, kind of commensurate with these studies, is really I always tell them that the first roadblock will be 6 months and then a year. And, usually at 6 months, you start to look for at least improvement in their sense of smell, whether sometimes it's just subjectively asking them. I mean, they will know how well their sense of smell improves. In our office, we use the University of Pennsylvania test to more objectively define any improvements. You can look at nasal congestion scores, SNOT-22, which have been validated symptom scores, and then a visual analog score. And then probably most importantly as well is nasal endoscopy in the office to look for regression of the polyps. And again, if there's no improvement in these at 6 months, that's kind of when you stop. You decide, do they need to switch biologic agent? And again, there isn't clear data yet as to which one to start with first. Again, like Dr. Hahn had mentioned, if you have a patient with CRS with polyps and atopic dermatitis, then dupilumab is your obvious choice. But again, if they don't have a lot of those other comorbid diseases, then which one do you start with? So again, if at 6 months there's not much improvement, then you may want to consider another biologic or surgery. If the answer is yes, they have improvement in these findings, patient thinks that they're thrilled with the medication and their improvement, then you continue on. If they're not completely happy with their improvement in the symptoms, or their nasal endoscopy score is not improved drastically, then you can consider treating with a short course of steroids to kind of boost them and get things moving. And then again, you monitor at 12 months. And this will be kind of the point at which you decide, is this biologic working for the patient? Do we need to consider transitioning them to another biologic agent, doing revision surgery? If you have these objective findings, then yes, you continue on. And again, the studies are still pending as far as what happens when you stop them and how long you can stop them for, what the duration of the treatment is. Again, going back to counseling your patients, for a lot of us, and actually this paradigm may be changing with all the new weight loss medications because people are a little more comfortable with giving themselves shots, but for a while there, you had to counsel your patient on being on an injection that most of them are going to be giving themselves at intervals, and on this medication indefinitely. I mean, those are two hard things for patients to hear, especially if they're haven't come to terms with the chronicity of their disease. And so those are very important conversations with these patients. So polling question 2, rethink your choice. When do you first evaluate a patient's response to biologic treatment? Answer 1, 1 month after treatment initiation. 2, it would be 3 months. 6 months after treatment initiation. 12 months, or I'm not sure. Great. So it looks like a lot of you have agreed, especially on the post-assessment 6 months after initiation. That's exactly correct. So here's another slide kind of summing up, how we define the response to these biologic therapies. And again, looking at the criteria of reduced nasal polyp size on nasal endoscopy, a reduced need for systemic steroids during that time frame, and then looking at quality of life through, SNOT-20, nasal congestion scores, an improved sense of smell, and a reduced impact of other comorbidities, especially asthma. And, at 6 months and then at 12 months, you kind of reassess to decide if you're going to continue or discontinue. This slide kind of looks at, what is the current and future role of imaging in CRS with polyps. Obviously, imaging is key, especially in those patients who will be considering surgical intervention for surgical planning. It often is a guide for, post-treatment response. And so CT obviously remains the gold standard as compared to MRI. MRI complements, especially if there's any evidence of intraorbital or intracranial involvement. As with all other aspects of our lives, AI may take over. And, the thought is, will AI be able to read these images and determine, are these images commensurate with a, type 2 response or type 2 disease versus a non-type 2 disease? And that may be an added criteria to help you decide if you're going to start a biologic or how successful surgery may be. As far as using imaging to monitor for patients' response to biologics, I don't know about your practice, Dr. Hahn, but in my practice, I rely more on nasal endoscopy rather than imaging, as well as obviously patient symptom resolution. In talking about how to identify patients with, type 2 disease, there was a study that looked at different ethnicities, and there was definitely more of a type 2 mediated disease as far as CRS with polyps in those patients from Europe versus Asia. It went on to even look at second generation Asian Americans, and there was still that reduced propensity towards a type 2 mediated disease. So there is thought that it's more of a genetic than an environmental component at this point. So what do we still need to know about biologics? A lot. We know how to identify patients. We know how to monitor their treatment. Other important things would be biomarkers. Can we test for the different interleukins that may serve to identify which one of these we start preferentially with the initial treatment? Duration of therapy, like Dr. Hahn had mentioned, a lot of the studies have looked at termination of the medication and persistence of symptom resolution, and that may help to even improve upon how often the patients are giving themselves the medications. The definition of what a remission means, criteria for switching, and then an important aspect would be what do we do with these biologics in terms of pre-treatment, during surgical treatment, and post-treatment? And I think that is probably the most interesting direction that we're going in. I mean, obviously, we all know that the importance of corticosteroids pre-surgery. The studies have really defined that, there's an improvement in surgical outcomes, bleeding during surgery. Can that carry over to starting someone on biologics a month before surgery, 2 weeks before surgery, and continuing them on that? So I think that there are a lot of interesting papers to come on that. These are phase 4 trials in the works, kind of looking at that. So, there's one with mepolizumab alone compared to in-office polypectomy and mepolizumab during a 52-week trial. Again, mepolizumab alone versus mepolizumab and functional endoscopic sinus surgery. And then similarly with dupilumab and its interaction with surgery. And then lastly, again, like I touched on, the importance of having multi-specialty involvement in these patients. I always tell my patients that their disease is based on anatomic consequences, inflammatory consequences, and so that requires them to be seen by multiple specialists, not just an ENT does kind of deal with, we're surgeons and medical specialists, but, we do need to include other subspecialties such as pulmonology, allergy, immunology. And I think it also is important to start with the primary cares to make sure that if they identify patients who are, type 2 inflammatory type patients to get them into our offices sooner. And then obviously continuing that communication between clinicians and patients, and then even your roles as PAs and seeing these patients in the office as well to kind of determine what the best treatment is. Is it revision surgery? Is it putting them on a biologic? Is it still getting them to see a pulmonologist when they've been treated for asthma by their primary cares, but haven't seen an asthma specialist? I think another important thing that just anecdotally is the involvement of your office staff, because the burden of putting patients on these biologics paperwork-wise is quite cumbersome. And I think a reason why a lot of people aren't moving into using biologics, frankly. If you think about the world of biologics, ENTs are late to the game. We've had rheumatologists, allergists, pulmonologists using biologics, and it's funny, talking with my partners I have 13 partners, and their solution to putting someone on a biologic is to refer them to me. And you may get this as well. And because frankly, I think there's a myth to biologics, and the myth of, more than, cumbersome monitoring, blood work, and it's not necessarily true. So this slide just kind of shows a lot about the multidisciplinary efforts required to treat these patients. So that's all I had. Conclusions, things that we've kind of discussed is, CRS with polyps, as you all know, is a significant problem for a lot of our patients. The studies have really shown a severe impact on quality of life, loss of productivity at work. And as we know, this is a chronic condition. It's refractory to a lot of the medications that we've typically been using, both medical treatment and surgical treatment. CRS with polyps is usually characterized by type 2 inflammation. We saw all those inflammatory pathways, and where the biologics do interfere those pathways and promote symptom resolution. We talked about type 2 directed biologic therapies for CRS with polyps, indications for it, patient selection, and patient monitoring. And then I think that pretty much sums up the last bullet point there. But that's it. We'll open up for questions at this point.
So we have several questions that have been coming down through our presentation. So the first question is there any contraindication for a biologic? I'm assuming biologic for the use of nasal polyps. And what about pregnancy with using the biologic? And so do you want me to go ahead and take that, or do you want?
You can go.
Yeah. So I would say we don't know, right? So when we did all these biologic studies for nasal polyp, if you are pregnant, you were excluded. So we don't know anything about it, and that is what the warning says. Now, with that being said, patients get biologics by accident without knowing that they're pregnant. And then if they don't know if they're pregnant, but they got a biologic, there's a registry. And this is a registry not run by the government or anything. It's one institution that's running that. And you actually do the registry and have them register to it. And I think that's important because people did that. Omalizumab was found to be safe in patients who are pregnant because of that registry. And it took 20 years to get that information. And so right now we don't know, but if a patient got a biologic, and didn't know they were pregnant, have them go in the registry. Whether or not they continue on that biologic, I would leave it up to the discussion between them and their OB physician or their provider to decide whether or not they want to stay on it. But definitely they should go on it. The other question, I think this question is actually kind of interesting. If you don't mind, can I?
Yeah, go ahead.
Yeah. So the next question, and actually this is similar to a lot of other questions that have come up, and I think this is such an exciting question. And so what it says is, is there a difference with any medical problems with the biologic for asthma nasal polyp versus biologic for inflammatory arthritis? And the answer is absolutely. There's difference between the two, right? So when you're thinking at like psoriasis or inflammatory arthritis, it's type 1 inflammatory disease or type 3 inflammatory disease, right? It's a non-type 2 disease. When you're looking at asthma nasal polyp, it's a type 2 disease. And so, when I give talks on biologics internationally, I get a common question: does biologic cause cancer? Right? And in fact, when omalizumab was first introduced, they actually had a black box warning saying that omalizumab can possibly cause cancer. But now we know that's not true. That FDA got rid of that black box warning. And in fact, any biologic that targets asthma or respiratory or the type 2 diseases don't cause cancer. While if you have a biologic that targets a non-type 2 disease or a type 1 or a type 3 disease, it can cause cancer, and that's one of the things that you need to talk about. Now, and I can't tell you how important it is to have that multidisciplinary approach. And, for us at EVMS, we have this thing called the Severe Asthma Consortium, and we have the pulmonologists, the allergists, and the ENTs all together. And, when we're trying to put a patient on a biologic, whether it be for asthma or nasal polyp, we all kind of talk to each other and say, hey, what do you want to do? Or which biologic should we do? Or if it doesn't work, which one do we switch it over to? Now, we didn't include rheumatologists in there. But now we're starting to include rheumatologists, because you know why? A lot of these patients that we see with asthma nasal polyp also have inflammatory arthritis. And you know what we're starting to see? We're starting to see, and I'm not sure if you're seeing the same thing, but we're starting to see that if we give them a type 2 biologic, it somehow affects the non-type 2 disease. And then when the patients get a non-type 2 biologic, it affects their asthma nasal polyps. So now I'm calling the rheumatologist and saying, hey, what do we do? You're giving them rituximab, and it's causing problems with their asthma and nasal polyps. And he's saying, like, yeah, you're giving your type 2 biologic, and it's causing problem with their inflammatory arthritis, or maybe even their psoriasis. And so now we're starting to include the rheumatologists in this discussion about what to do, and then we're trying to constantly juggle which one do we use. And so, and I think that's kind of answering some of the other questions that you guys had, because in general, type 2 biologics are very safe. There's very little problems. Yes, if you're allergic to the protein, because most of these biologics are IgGs, right? IgG1, IgG4, different types of immunoglobulin. So it's a protein, a big protein. And so you can have an allergic reaction to it. Now it's humanized, meaning it's more human than anything else. And so because of that, it's less likely to have the hypersensitivity reactions, like less than 1%, but it's still there. So you do have to worry about that, but it's very, very low. And I think in general, these type 2 biologics are fairly safe.
Yeah, I would agree. I can tell you, I can count on one hand the number of patients I've had to take off because of side effects, and so they're quite safe.
Yeah, and then okay. So do you want to answer the next question? Differential indication, which biologic do you choose in which patient?
And I think that's where a lot of the research is going to go. You could see that a lot of the studies that are out there, especially one being completed in 2025, to look at kind of the head-to-head comparison between omalizumab and dupilumab. Again, like Dr. Han had discussed, if there are any other comorbid conditions that would indicate one versus the other. Sometimes it's the way it's given. One is every 4 weeks, another one is given every 2 weeks. And again, for a patient who's never given themselves an injection before, that extra 2 weeks in between doses does make a difference for some of them. And so I find that even a third criteria is ease of getting the medication for some of the patients. There is a difference, I think, and my office staff would agree, between getting them approved by insurance and even working with the company. So it's also ease of the patient getting the medication delivered to them. That makes a difference.
Yeah, and then that is a factor that as we as healthcare providers don't think about, right? But unfortunately, like the insurance companies are dictating to us which biologic the patient can get. So, at one time, if someone had nasal polyp, I would write all 3 biologic and see which one came back first.
Yeah.
So.
Yeah. And it's also, speaking with a lot of pulmonologists and allergists, it's actually easier for the ENT world to get these biologics approved. Than the criteria for asthma is much more stringent. So I find that quite fascinating. I mean, it really is, it's way less paperwork for us to get these approved than for allergists and pulmonologists.
And so the next question is, can a biologic like Dupixent affect skin prick testing or allergy testing? And I think the answer is we don't know, but I will tell you my guess as a clinician scientist. So, when dupilumab first came out, it was approved in 2019 before COVID in 2020. And so when that came out, a lot of people were saying, a lot of the immunologists were saying, hey, you can't give them COVID vaccine with dupilumab because what does dupilumab do? It blocks IL-4, then it prevents the plasma cell from differentiating into plasma cells, then you don't get the immunoglobulins, and the vaccine effect will be low or maybe non-existent. I mean, it made sense. But in reality, it didn't hold to be true. So I think it seemed to show that dupilumab doesn't affect the vaccine efficacy, but that is still on one of the labelings because it hasn't been officially studied. But for those small studies that have looked at dupilumab and vaccine, it doesn't seem to affect the vaccine efficacy. Now, with that being said, I don't think dupilumab also affects allergy testing as well. So oral antihistamine does, but for dupilumab to affect the whole allergy testing, whether it be even immunoassay, it takes a long time. And so when you're doing allergy skin prick testing and stuff, those are more immediate response. And so I don't think it will affect skin prick testing, allergy testing, whether it be skin prick testing or radioimmunoassay to a certain level, unless it's long term.
Here's an interesting question. What are the certain things that need to be seen or documented for insurance for these biologic medications? And then second question, and to continue care, what other things do you continue even though they're on a biologic and having a good response to it? So, for nasal polyps, it's just documenting the nasal polyps and failure to other medications, kind of generally what I would put in all of my notes. I'll put in my notes nasal polyp score on endoscopy, what medications they've failed, how many rounds of systemic steroids they've been on in the last 12 months, comorbid conditions, asthma, what maintenance therapy they're on for asthma, how many times a year do they have exacerbations, and then their allergic profile. Talking to, people on the insurance side, my medical staff, people in pharma, I mean, honestly, it really just comes down to documenting the severity of polyposis and failure of medications. That's the biggest key. And then As far as what do you do treatment-wise once people are having a good response, because now, we all have patients who are a good 2 years on the medications, 2 to 3 years. And I don't know about you, but I've, been reducing their even topical steroid treatment. So certainly all my patients who are on steroid rinses, I've cut that back. I've seen that just very few of them even need that. I continue them on their allergy treatments, but really I try to reduce even topical steroids as well.
Yeah, and I think, thank you for staying. I think we went over a little bit, but we'll be here down to answer any questions. So thank you very much for attending our session.